just get started here. This won't take us too long. We're going to talk about just a couple short cases today and just review everything that we learned about last week. So it's the ILD Community Network. And of course, I'm Heather. I'm from Henry Ford Hospital, Detroit, and Iris Zink, also from Pine Hollow Partners. Nice to see everyone again. And thanks to the sponsors, Boheim Ingerheim and founding sponsor and platinum sponsor, United Therapeutics, who helped us get this set up. So we appreciate that very much. So we're going to talk today about uncovering the clues, a case-based journey through ILD and rheumatic disease. And we learned quite a bit about that last week as well. Case number 1 is called, I thought rheumatoid arthritis was about the joints. And obviously, that's what we think about when we hear and we learn first about rheumatoid arthritis. It's about joint pain and joint swelling and that kind of thing. But there's a lot more behind it as well. Do you want to touch base a little bit about that, Iris?
Yes, certainly. We know that it can certainly affect the lungs, so they're not as pliable. They're more fibrotic, more like brown paper bags instead of like rubber balloons. And so that's why we listen to all of our patients' heart and lungs every single time on skin to make sure that we're not seeing that happen.
Right. So rheumatoid arthritis can affect the lungs, causing that inflammation in the lungs. Of course, we can't see that from the outside of the patient, but the patient can be having a lot of inflammation and then, like Iris said, fibrosis in the lungs as well from their underlying autoimmune disease. So something to keep in mind. So the first patient here is a 67-year-old male, and he was complaining of increasing fatigue and shortness of breath with mild exertion over the last 6 months. The patient had seropositive rheumatoid arthritis for 4 years already. He had that high rheumatoid factor of 300 and an anti-CCP of 60, so both high there on his labs. And he was on methotrexate. He also was on the adalimumab, or also known as
Humira.
Right.
Much easier to say.
Right. And he had that added on 2 years ago because he had ongoing disease activity. But just a question about the case to think about: what features in this history suggest a higher risk for ILD? Do you want to touch base on that, Iris? Just what features, when you looked at that case in your clinic, would you think, oh, he might have ILD or he might get ILD?
Certainly that he's a man and that he has very aggressive disease are the two big factors there, because his rheumatoid factor is really high, and
Right.
because he's a man, he's at higher risk, and because he's African American. It looks like in the picture, I don't know, I can't assume, but African Americans also have increased
Risk of ILD. Yeah, his rheumatoid factor very high there with a very high titer. So 90 to 100, around 90 to 100, you can think of a high risk for rheumatoid arthritis related ILD, and his is greater than 300, so very, very high. So he had the crackles on auscultation when we listened to this patient. His sats were fine though. His oxygen sats were normal at rest, which is typical, but he started to desaturate when he was walking around. They did a chest x-ray on that. It showed the interstitial markings. And then the ordered breathing tests, or PFTs. And the numbers there were the FVC, or the forced vital capacity, was 65, so that's low. And the diffusing capacity, the DLCO, also low at 41%. So he had a restrictive pattern on the PFDs. And then with the CAT scan that they eventually ordered, it showed these basal predominant reticulation with honeycombing consistent with a UIP pattern. That just means that it's a usual interstitial pneumonia pattern on the CAT scan that the radiologist sees. The honeycombing is the scarring pattern that we see on the CT scan. The question at the bottom here says, oh, sorry, what were you going to say, Iris?
I was going to say that you should just mention too what the normal forced vital capacity is, because we would automatically think it would be 100%.
Right. Normal can be like 80% depending on the height, weight, and that of the patient and age of the patient. So normal could be 80 to 100, or even a little bit more sometimes depending on the patient and the calculation the computer does. But his is 65, so it's on the downward, definitely low. And so, and then the guidelines that the chest ACR talks about, what do we recommend next for suspected rheumatoid arthritis ILD? That's the question. So it looks like we've already done the CAT scan. We've already done the PFTs, which are important to do. And the next thing would be referral to pulmonary team, and to establish a diagnosis in a multidisciplinary meeting, which is a big group that gets together every week with the radiologist, the pathologist if needed, and then a couple different pulmonologists and the whole team. They get together to discuss the case, and then they kind of find out or figure out the diagnosis together. So they confirmed that he had the rheumatoid arthritis ILD with the UIP pattern on the CAT scan. So he was on the two medications that we talked about, methotrexate and adalimumab. And he had the high titer, like we said. He was older age, male sex, and he had the positive anti-CCP as well. So he was a high profile. The question there was, what baseline and follow-up assessments would you need to establish for this patient, and should methotrexate be continued or not? So the baseline we already have. We already have the PFTs, the HRCT. We're going to talk about what to do about his medications, but we're going to start him on the antifibrotic medication. In this case, it was nintedanib that we started him on, and we continued low-dose prednisone for a short term, I guess. And then they did end up switching the medication for the rheumatoid arthritis. Do you want to talk about that real quick, Iris?
Yes, they switched him to abatacept. What's wrong with this is that, he was on methotrexate for 4 years before even the biologic was added in the first place, before he got on adalimumab. So, there could have been progressive damage going on. And then they switched him to abatacept, which is a lovely choice because it's super safe. Like, the infection risk on that particular drug is very, very low. But, I would have probably thought about an interleukin-6 medication that would have antifibrotic capability instead, because that might help his lung disease too. So abatacept is certainly a choice, but there may be a better choice for his rheumatoid arthritis.
Okay. And then they gave him the vaccine. We gave him the vaccines, very important with patients that are on immunosuppression medication and have lung disease already. So they did the pneumococcal influenza COVID booster, of course, and then kept on checking on him every 3 to 6 months with PFTs. And then we always do the high resolution CT every year at least. We do it more frequently sometimes if we notice a significant change in the patient. We could do it sooner, but at least every year. What evidence supports antifibrotics in rheumatoid arthritis, ILD? I guess the evidence that the patient was getting worse. He was more short of breath. So he was progressing. His PFTs were dropping. And then we've seen the pattern on the CAT scan that showed he had fibrosis there. So that's why we need to get the antifibrotics going. We already talked about the biologics preferred. So a summary about that case was just that the high-risk rheumatoid arthritis patients need to be proactive screening for ILD. The CAT scan and the PFTs play critical roles for early identification. And then UIP, which is that pattern on the CAT scan that we see, carries a poorer prognosis. That means that the early scarring has started and the scarring has started in the lungs. But antifibrotics, we talked about those last week, can slow the decline of the fibrosis in the lungs. It can't take it away or improve it, but it does slow that decline, because we know with lung scarring, it will progressively get worse. And then we also want to talk with our rheumatoid partners and, share the decision-making on what kind of medications and what else to treat him for his underlying rheumatoid arthritis.
Fabulous.
And then the next case, I'll have Iris talk about this one a little bit more, but this is another case called It's Getting Harder to Breathe, and it was progressive ILD and systemic sclerosis. Go
So
ahead.
DA is a 56-year-old Caucasian woman with a chief complaint of worsening dyspnea over the 6 months and dry cough. She has a known history of diffuse cutaneous systemic sclerosis for the past 2 years. And remember, there's 2 types of scleroderma. There's the limited, and then there's the systemic sclerosis, which is the bigger one that affects the internal organs more. Her clinical features, she had skin thickening, proximal to her elbows, Raynaud's, and she had GERD. And antibody profile was she was positive for SCL70. So she has a very high risk of developing interstitial lung disease because is more proximal and she's SCL70, that makes us think of the bigger systemic sclerosis. And then for any patient with scleroderma, even limited or diffuse scleroderma, we tend to do baseline PFTs and high resolution CTs, and I do a chest X-ray too on these patients. So her ILD onset was her worsening dyspnea over the 6 months. She had desaturation on exertion. We did one of those 6-minute walk tests where we had her walk around the office for 6 minutes and with the pulse oximeter and to see if she did desat, and she did. And her pulmonary function tests were, go ahead.
Oh, so the pulmonary function test, hers was 71, so it's still, like, a little low, but it's not too bad. The FVC, the forced vital capacity, the DLCO, the diffusing capacity, 52, so it is going down as well, and it says here it was downtrending from baseline, so maybe we did have one from before, and it was going down. And then on the HRCT, she had that early honeycombing with a UIP pattern. So we know that that's a sign again of scarring in the lungs, likely to get worse, likely to progress.
Mhm. And so the next steps in management and, what do we do? So certainly we're gonna send her to pulmonary as soon as possible, and then we need to look at some kind of remittive drug because it doesn't talk about her being on any remittive drug. So from a rheumatology standpoint, we would think about MMF in this patient.
Yeah. Or mycophenolate.
Yep, exactly. So MMF or myclophenolate was initiated. We referred her to transplant clinic for consideration, and we reviewed the vaccines and introduced the idea of palliative care, probably not on the first or second visit. But we talked about that, because we want her to be comfortable. We want to talk about, pulmonary rehab and all the things that Heather's going to talk about.
And so, yeah, so we talked about this last week too, but just to review that, making sure that the patient is active if possible. Pulmonary rehab, if they need to, is really important, especially if you're considering, transplant. I don't know that she needs oxygen. I'm not sure. But if she did need oxygen where we're looking at transplant, we need to do pulmonary rehab, get her going on that so she can build up the muscles around her lungs, exercise, vaccines, healthy lifestyle, all of that. And how do you monitor and adjust her therapy? Are we talking about the mycophenolate there, Iris?
I don't think so because I think it's my job to put her on myclophenolate, the MMF, get that started because there really isn't a drug for scleroderma that's really going to slow the progression. It's really up to pulmonology, unfortunately, to go from there to see how much we can save at that point.
Okay.
When there is a drug for scleroderma, that's going to make things much, much easier, but there isn't really a drug for scleroderma that's going to help with this part.
Okay. So, so as far as we're doing the lab monitoring too, we often check it every 3 months if they're on mycophenolate, 3 to 6, that kind of thing, just to make sure that the blood cells fine, the liver enzymes, the kidneys, all of that, and then adjustment of therapy. Um, we usually put our patients who have ILD on the highest dose of CellCept that they can tolerate, so 1,500 BID. What about you, Iris?
Certainly, we try to maximize the medication as much as we can, as long as they're tolerating it and their blood pressure is tolerating it and everything.
Yeah, and then adding the antifibrotic as well, with this patient, so we could add that on, and then monitoring her PFTs every 3 months for sure to make sure that they're hopefully staying a little bit steadier, and not declining too quickly. And then the CAT scans again every year. So just the summary here. So we just talked about this last case that was diffuse systemic sclerosis, recognizing that they're high risk for ILD as well. Importance of early recognition of progressive fibrosing ILD. Remember that it's a progressive disease. It will more than likely get worse. They will, as they get worse, they'll need oxygen, and eventually, could end up in respiratory failure. So really important to recognize it early, initiate the immunomodulatory therapy and the timing of the antifibrotic fairly soon on as well. Timing of referral to transplant is, absolutely, if they're on oxygen, they need to go to transplant, at least be referred. But even early on, if they're low on their breathing tests, on their PFTs, if those numbers are running low, and if they have extensive scarring in the lungs, we need to talk about transplant and get them referred over. Use of antifibrotic early if possible. The earlier, the better for that kind of medication, so we can slow the progression of the scarring down.
That was perfect. And then I think key takeaways are what Heather's taught us, that you absolutely have to do the high resolution CT scan. You absolutely have to do the pulmonary function test for, checking these patients, even though sometimes these patients come to us and we kind of watch them for a minute to see what their scleroderma is going to do. Once they get into interstitial lung disease land, you're in a whole different area where we have to be much more aggressive with those. And how has it shaped your interstitial lung disease suspicion and management of the framework? Certainly, we know what the high-risk patients are: patients with scleroderma, patients with aggressive rheumatoid arthritis, patients who've had industrial exposures, things like that. And what is part of your diagnostic timeline, treatment timeline? What do you feel most confident and least confident? I think the pulmonary function tests every 3 months, and then making sure that we're getting the high-resolution CT scans for monitoring. And really, the most important thing is making friends like Heather, so that we have someone that we can touch base with and ask questions too.
For sure. And I just wanted to point out too that a lot of our patients are stable too. Not all of them are, declining really, really quickly. I see many patients who get on their therapy for their underlying autoimmune disease, and even in addition with an antifibrotic, and they are stable and doing well without decline. So that's really great to see. But I think early recognition is really, really important. So that's where the community comes in to find these patients when they suspect it, and kind of go from there and lead the way to referrals and that kind of thing to help the patient out.
Absolutely. And we're hoping in the future there's going to be more medications for scleroderma and systemic sclerosis, so we can slow it down on the front side. But right now, we just have the old fashioned stuff.
Oh, I guess that is the end of the slideshow.
Yes.
So whoever joined, thanks so much
Mhm.
for coming last week and this week. And hopefully the case studies you remember them, and you know, you recognize that early. I think a lot of the people who were there last week already had an idea about ILD because they were in the rheumatological clinic. And we had some people from primary care as well, which was nice.
Mhm. Was.
So,
Are there any questions before we sign off? Anyone?
None for me. Great job. That was great. Super interesting.
Thank you. Claudia, do you have anything to say about the scleroderma? I mean, would you have done things differently?
No, there's just nothing for scleroderma right now, fortunately. But hopefully in the future. But no, that makes sense.
Great. Thank you all.
Thank you, Heather and
Heather.
Iris, and thank you, Claudia. Have a good night, everyone.
yes, everyone have a good night. Great to
Thank
see
you for the
you.
sponsors. Bye-bye.
Bye.
Thank you. Bye, Ollie.